Welcome to Nurses Lab. Welcome to your AHA, AAP, NRP 2025 Updated Exam Preparation Session. In this video, we're diving into 50 high-yield NRP questions that are built around the 2025 updates, covering the newborn chain of care, anticipation and preparation, cord management, initial steps, heart rate assessment, ventilation and CPAP, oxygen use, chest compressions, epinephrine and vascular access, volume expansion, post-resuscitation care, and the critical human factor elements of team training and performance. Whether you're preparing for certification, teaching others, or strengthening your clinical practice, these questions will sharpen your decision-making, reinforce key updates, and help you master the 2025 NRP standards. Let's begin. Question number 1. A term newborn is delivered vaginally. The baby is limp, apneic, and has a heart rate of 80 per minute after warming, drying, positioning, and stimulation. What is the next best action? A. Start chest compressions immediately. B. Provide positive pressure ventilation. C. Give epinephrine through umbilical venous catheter. D. Begin CPAP only. Correct answer is B. Provide positive pressure ventilation. Let's see its explanation. For a newborn who is apneic or gasping, or has HR less than 100 per minute despite initial steps, ventilation should be provided within 60 seconds after birth. Chest compressions are not the first step here because neonatal bradycardia is usually due to inadequate ventilation. Question number 2. During resuscitation of a 39-week newborn who requires respiratory support at birth, what is the most appropriate initial oxygen concentration? A. 100% oxygen. B. 60% oxygen. C. 21% oxygen. D. 40% oxygen. Correct answer is C. 21% oxygen. Now let's see its explanation. For term and late preterm infants greater than or equal to 35 weeks who need respiratory support at birth, it may be reasonable to begin with 21% oxygen and then titrate to target saturation goals. Question number 3. A 30-week preterm newborn requires respiratory support immediately after birth. Which initial oxygen approach is most appropriate? A. Start with 21% oxygen only. B. Start with 21 to 30% oxygen. C. Start with 30 to 100% oxygen. D. Start only with 100% oxygen. Correct answer is C. Start with 30 to 100% oxygen. So, what about its explanation? For infants less than 32 weeks gestation, the 2025 guideline states it may be reasonable to begin with 30% to 100% oxygen and then titrate to target saturation goals. By contrast, 32 to 34 plus 6/7 weeks may begin with 21% to 30% oxygen. Question number 4. A newborn remains bradycardic with HR 50 per minute after initial steps and 30 seconds of ventilation that visibly inflates the lungs. What is the next step? A. Continue stimulation only. B. Start chest compressions. C. Give endotracheal epinephrine first. D. Suction the airway routinely. Correct answer, B. Start chest compressions. Let's see its explanation. Chest compressions are recommended when the heart rate remains less than 60 per minute despite 30 seconds of effective ventilation. Effective ventilation must be established first because it is the most important intervention in neonatal bradycardia. Question number 5. When chest compressions are being performed in neonatal resuscitation, which technique/rhythm is most appropriate? A. 15-2 with 2-finger technique. B. 30-2 with 1-hand technique. C. 3-1 with 2-thumb encircling hands technique. D. Continuous compressions without ventilation. Correct answer is C. 3-to-1 with 2-thumb encircling hands technique. So what about its explanation? The preferred neonatal approach remains 3 compressions followed by 1 ventilation breath, 3-to-1. It is also reasonable to use the 2-thumb encircling hands technique with compressions over the lower 1/3 of the sternum to a depth of about 1/3 of the anterior/posterior chest diameter. Question number 6. A 36-week newborn is not improving with face mask ventilation. Which airway statement is most accurate? A. Laryngeal mask is contraindicated in all newborns. B. Laryngeal mask is reasonable as an alternative to intubation if face mask ventilation is unsuccessful. C. Direct transition to chest compressions is preferred. D. Suctioning must always be repeated first. Correct answer? B. Laryngeal mask is reasonable as an alternative to intubation if face mask ventilation is unsuccessful. Now let's see its explanation. For newborns 34+07 weeks or more, a laryngeal mask is a reasonable alternative to endotracheal intubation when face mask ventilation is unsuccessful. It may also be considered during chest compressions in infants greater than 34 weeks if intubation is not possible or unsuccessful. Question number 7. A newborn is receiving chest compressions and still has HR 40 per minute after ventilation has been optimized. Which epinephrine choice is most appropriate? A. Endotracheal epinephrine 0.01 to 0.03 milligrams per kilogram is preferred over vascular access. B. Intravascular epinephrine 0.01 to 0.03 milligrams per kilogram. C. Intravascular epinephrine 0.1 milligram per kilogram. D. No epinephrine should be given in neonatal resuscitation. Correct answer? B. Intravascular epinephrine 0.01 to 0.03 milligrams per kilogram. Let's see its explanation. If HR has not increased to greater than 60 per minute after optimized ventilation in chest compressions, intravascular epinephrine 0.01 to 0.03 milligrams per kilogram is recommended. Endotracheal epinephrine can be given while vascular access is being obtained, but intravascular delivery is preferred. Question number 8. While obtaining vascular access for a newborn who needs epinephrine, which endotracheal dose is reasonable? A. 0.001 milligram per kilogram. B. 0.01 to 0.03 milligram per kilogram. C. 0.05 to 0.1 milligram per kilogram. D. 0.2 milligram per kilogram. Correct answer, C. 0.05 to 0.1 milligram per kilogram. Let's see its explanation. While vascular access is being obtained, it is reasonable to give endotracheal epinephrine 0.05 to 0.1 milligram per kilogram because a higher dose is needed by the ET route than by the intravascular route. Additional doses may be given every 3 to 5 minutes, preferably intravascularly, if HR remains less than 60 per minute. Question number 9. A newborn is breathing spontaneously but has respiratory distress after birth and is preterm. Which respiratory support strategy is most appropriate? A. Immediate routine intubation for all preterm infants. B. CPAP is reasonable rather than intubation and mechanical ventilation. C. Chest compressions should be started. D. Only supplemental oxygen without distending pressure. Correct answer, B. CPAP is reasonable rather than intubation and mechanical ventilation. So what about its explanation? For spontaneously breathing preterm infants who require respiratory support immediately after birth, it is reasonable to use CPAP rather than intubation and mechanical ventilation. Question number 10. Which statement about umbilical cord management is most accurate according to the 2025 guidance? A. All newborns should have immediate cord clamping. B. For preterm infants less than 28 weeks, intact cord milking is recommended. C. For infants less than 37 weeks not requiring immediate resuscitation, deferred cord clamping for at least 60 seconds is recommended. D. Cord management does not affect neonatal outcomes. Correct answer, C. For infants less than 37 weeks who do not require immediate resuscitation, deferred cord clamping for at least 60 seconds is recommended. For infants less than 28 weeks, intact cord milking should not be performed because of harm risk. For non-vigorous term and late preterm infants greater than 35 weeks, intact cord milking may be reasonable compared with immediate cord clamping. Question number 11. A term newborn is born through clear fluid. After initial steps, the infant is gasping and the heart rate is 90 per minute. The team leader says, start compressions because the heart rate is below 100. What is the best response? A. Start compressions immediately because HR is less than 100 per minute. B. Start PPV because ventilation is the priority when HR is less than 100 per minute or the infant is apneic, gasping. C. Give epinephrine first because bradycardia is present. D. Provide blow-by oxygen only. Correct answer is B. Start PPV because ventilation is the priority when HR is less than 100 per minute or the infant is apneic, gasping. So let's see its explanation. This is a classic trap. In neonatal resuscitation, HR less than 100 per minute does not mean compressions. If the newborn is apneic, gasping, or has HR less than 100 per minute after initial steps, the next intervention is positive pressure ventilation, ideally started within the first minute after birth. Compressions are reserved for HR less than 60 per minute after effective ventilation. Question number 12. A 31-week preterm newborn needs respiratory support at birth. Which initial oxygen plan is most appropriate? A. Begin with 100% oxygen. B. Begin with 21% oxygen only. C. Begin with 30 to 100% oxygen and titrate by pre-ductal saturation. D. Begin with room air and do not use pulse oximetry yet. Correct answer is C. Begin with 30 to 100% oxygen and titrate by pre-ductal saturation. Now let's see its explanation. For infants less than 32 weeks gestation, the 2025 guidance supports starting with 30 to 100% oxygen, then titrating based on pre-ductal pulse oximetry. This is a common trap because many learners overgeneralize room air starts from term infants to very preterm infants. Question number 13. A 33-week newborn is breathing spontaneously but has persistent respiratory distress immediately after birth. What is the most appropriate initial respiratory support? A. Immediate endotracheal intubation for all preterm infants with distress. B. CPAP is reasonable rather than routine intubation and mechanical ventilation. C. Chest compressions because respiratory distress predicts cardiovascular collapse. D. Free flow oxygen alone without distending pressure is preferred. Correct answer is B. CPAP is reasonable rather than routine intubation and mechanical ventilation. Now let's see its explanation. For a spontaneously breathing preterm infant who needs support, CPAP is reasonable and often preferred over routine early intubation and mechanical ventilation. The trap is assuming every preterm infant with distress needs intubation. Question number 14. A newborn has been receiving PPV by mask. Chest movement is poor. The heart rate remains 70 per minute and the infant is not improving. What should the team do next? A. Begin chest compressions because HR is trending down. B. Continue ineffective PPV for another minute before changing anything. C. Correct ventilation and ensure effective lung inflation before considering compressions. D. Give epinephrine immediately by ET tube. Correct answer, C. Correct ventilation and ensure effective lung inflation before considering compressions. Now let's see its explanation. Another high-yield trap. Neonatal bradycardia is usually due to inadequate ventilation. If PPV is not effective, the correct response is to optimize ventilation first. Chest compressions are indicated only after effective ventilation has been achieved and HR remains less than 60 per minute. Question number 15. A newborn's HR remains 50 per minute after 30 seconds of effective PPV with visible chest rise. What is the best next step? A. Continue PPV only. B. Start chest compressions coordinated at 3:1 with ventilation. C. Shock the newborn. D. Give sodium bicarbonate first. Correct answer, B. Start chest compressions coordinated at 3:1 with ventilation. So what about its explanation? When HR remains less than 60 per minute after 30 seconds of effective ventilation, chest compressions should begin. The recommended neonatal method is 3 compressions to 1 ventilation, with the 2 thumb encircling hands technique, using 100% oxygen during compressions. Question number 16. During chest compressions, one provider suggests switching to a 15:2 ratio because that is used in some pediatric CPR situations. What is correct for neonatal resuscitation? A. 15:2 is correct if 2 providers are present. B. 30:2 is correct if the infant is intubated. C. 3:1 is the recommended ratio in neonatal resuscitation. D. Continuous compressions without breaths are preferred. Correct answer, C. 3:1 is the recommended ratio in neonatal resuscitation. Let's see its explanation. Neonatal arrest physiology is usually asphyxial, so ventilation remains central. That is why the neonatal ratio is 3:1, not the pediatric BLS ratios used later in infancy-childhood algorithms. Question number 17. A newborn is undergoing compressions with effective ventilation and 100% oxygen. After 60 seconds of coordinated compressions, the HR is still 40 per minute. Which medication plan is most appropriate? A. Delay medication and continue compressions for 5 more minutes before deciding. B. Give intravascular epinephrine through UVC or IO access. C. Give atropine first. D. Give adenosine rapidly IV. Correct answer, B. Give intravascular epinephrine through UVC or IO access. Now let's see its explanation. If HR remains less than 60 per minute, despite effective ventilation and 60 seconds of chest compressions, epinephrine is indicated. The preferred route is intravascular, and in the 2025 neonatal algorithm, this is UVC or IO, with repeat dosing every 3 to 5 minutes if needed. Question number 18. During a difficult neonatal code, UVC access cannot be obtained quickly. Which statement is most accurate? A. IO access is not acceptable in newborns. B. Endotracheal epinephrine must be avoided completely. C. IO access is acceptable if UVC is not feasible, and ET epinephrine can be used while access is being obtained. D. Medications should be withheld until UVC access is established. Correct answer, C. IO access is acceptable if UVC is not feasible, and ET epinephrine can be used while access is being obtained. So what about its explanation? A common trap is thinking only UVC is allowed. The 2025 neonatal algorithm explicitly allows UVC or IO access. ET epinephrine may be used temporarily while vascular access is being secured, but vascular delivery is preferred. Question number 19. A non-vigorous term newborn is born through meconium-stained fluid. The baby is apneic and limp. One provider wants immediate routine tracheal suctioning before ventilation. What is the best action? A. Routine immediate tracheal suctioning before ventilation. B. Start PPV if the infant is apneic or HR is low. Suction only if airway obstruction is suspected. C. Delay all respiratory support until meconium is fully cleared. D. Start compressions because the infant is limp. Correct answer, B. Start PPV if the infant is apneic or HR is low. Suction only if airway obstruction is suspected. Now let's see its explanation. The trap here is older meconium thinking. Current neonatal resuscitation emphasizes ventilation first rather than routine tracheal suctioning for non-vigorous meconium-exposed infants. Suctioning is considered if there is obvious airway obstruction interfering with ventilation. Question number 20. A newborn has received effective PPV, chest compressions, and epinephrine, but the HR remains less than 60 per minute. Which cause should the team specifically consider next according to the neonatal algorithm? A. Pulmonary embolism only. B. Hypovolemia and pneumothorax. C. Myocardial infarction. D. Stroke. Correct answer B. Hypovolemia and pneumothorax. Let's see its explanation. The 2025 neonatal algorithm specifically notes that if HR remains less than 60 per minute, the team should consider reversible causes such as hypovolemia and pneumothorax. Question number 21. A 39-week newborn is delivered by emergency cesarean section. After warming, drying, positioning, and stimulation, the infant is gasping with a heart rate of 70 per minute. A junior provider suggests intubating first because the heart rate is already very low. What is the best immediate action? A. Start chest compressions. B. Give epinephrine via UVC. C. Begin positive pressure ventilation. D. Provide only free-flow oxygen. Correct answer is C. Begin positive pressure ventilation. Now let's see its explanation. This is a classic neonatal trap. In neonatal resuscitation, gasping or HR less than 100 per minute after initial steps calls for assisted ventilation, not immediate compressions or epinephrine. The first physiologic problem is usually failed ventilation, not primary cardiac arrest. Question number 22. A 30-week newborn is placed on respiratory support immediately after birth. Which oxygen strategy is most appropriate at the start? A. Always begin with 21% oxygen. B. Always begin with 100% oxygen. C. Begin with 30 to 100% oxygen and titrate using pre-ductal saturation. D. Avoid oxygen until 5 minutes of life. Correct answer is C. Begin with 30 to 100% oxygen and titrate using pre-ductal saturation. Now let's see its explanation. For infants less than 32 weeks gestation, it may be reasonable to begin respiratory support with 30 to 100% oxygen and then titrate. This is harder because many learners over-apply the term infant 21% rule to very preterm infants. Question number 23. A 36-week newborn has persistent cyanosis and labored breathing, but is breathing spontaneously. The team debates whether to intubate immediately. What is the most appropriate next step? A. Immediate chest compressions. B. Consider CPAP and oxygen as needed. C. Give epinephrine because cyanosis is present. D. Delay intervention unless the heart rate falls below 60 per minute. Correct answer is B. Consider CPAP and oxygen as needed. So the explanation is, for a spontaneously breathing newborn with labored breathing or persistent cyanosis, the neonatal algorithm directs the team to use pulse oximetry, give oxygen if needed, and consider CPAP. Immediate compressions or epinephrine are not indicated here. Question number 24. A newborn has been receiving mask PPV for 30 seconds. There is minimal chest rise, and the heart rate stays at 65 per minute. Which action is best? A. Start chest compressions because the HR is below 100 per minute. B. Continue the same ineffective PPV for another minute. C. Perform ventilation corrective steps and optimize ventilation. Or D. Give intravascular epinephrine now. Correct answer is C. Perform ventilation corrective steps and optimize ventilation. Now let's see its explanation. Before compressions, the team must ensure ventilation that inflates the lungs, shown by chest movement, and ideally a rising heart rate. If ventilation is ineffective, the next step is ventilation corrective steps, with consideration of an alternative airway if needed. Question number 25. After ventilation is corrected, the newborn now has visible chest rise, but the heart rate remains 50 per minute. What is the best next action? A. Start coordinated chest compressions. B. Continue PPV alone because the HR is above 40 per minute. C. Give ET epinephrine before compressions. Or D. Start sodium bicarbonate. Correct answer is A. Start coordinated chest compressions. Now let's see its explanation. Chest compressions are recommended when the newborn heart rate remains less than 60 per minute, despite 30 seconds of ventilation that inflates the lungs. The most common trap is delaying compressions after effective ventilation has already been established. Question number 26. During compressions, one provider uses a 15-2 rhythm and another is using the two-finger technique. Which correction is most accurate? A. Change to 30-2 because neonatal arrest is treated like pediatric BLS. B. Change to 3-1 and use the two-thumb encircling hands technique. C. Continue 15-2 but increase oxygen to 100%. Or D. Keep two-finger compressions because the neonatal chest is small. Correct answer is B. Change to 3-1 and use the two-thumb encircling hands technique. In neonatal resuscitation, the recommended ratio is 3 compressions to 1 inflation, and the preferred compression method is the two-thumb encircling hands technique. This reflects the primarily asphyxial nature of neonatal arrest, where ventilation remains central. Question number 27. A newborn is intubated, receiving effective ventilation and undergoing coordinated chest compressions. The FiO2 is still 40%. What is the best correction? A. Leave oxygen unchanged until ROSC. B. Decrease oxygen to 21% to reduce free radical exposure. C. Increase oxygen to 100% during compressions. Or D. Oxygen concentration does not matter if the infant is intubated. Correct answer is C. Increase oxygen to 100% during compressions. Now let's see the explanation. During neonatal chest compressions, it may be reasonable to use 100% oxygen. Once compressions are no longer needed, oxygen should be titrated back to saturation targets. Question number 28. After 60 seconds of effective ventilation and coordinated compressions, the heart rate remains 45 per minute. UVC placement is proving difficult. What is the best medication/access plan? A. Wait until UVC is secured. No medication should be given before that. B. Use IO access if IV access is not feasible and give epinephrine intravascularly. C. Give atropine first through the ET tube. D. Stop compressions and attempt line placement only. Correct answer is B. Use IO access if IV access is not feasible and give epinephrine intravascularly. So what about its explanation? If HR remains less than 60 per minute despite 60 seconds of chest compressions and adequate ventilation, epinephrine should be given, ideally intravascularly. The umbilical venous route is preferred, but when IV access is not possible or feasible, IO may be considered. Question number 29. A 35-week infant has failed mask ventilation. Intubation attempts are unsuccessful. The infant still needs effective ventilation. Which option is most appropriate? A. Resume ineffective mask ventilation only. B. Use a laryngeal mask as an alternative airway. C. Start compressions because intubation failed. D. Delay airway management and observe for spontaneous recovery. Correct answer, B. Use a laryngeal mask as an alternative airway. Now let's see its explanation. A laryngeal mask can be used to provide initial ventilation, and if the heart rate does not increase with face mask ventilation, insertion of an alternative airway, such as a laryngeal mask or endotracheal tube, often improves effectiveness. For infants 34 weeks or more, a laryngeal mask is also a reasonable alternative when ET placement is unsuccessful, including during compressions. Question number 30. In the NICU, a recently resuscitated newborn suddenly deteriorates with persistent bradycardia despite effective ventilation, an advanced airway, chest compressions, and epinephrine. Which cause should the team specifically consider next? A. Myocardial infarction and stroke. B. Hypovolemia and pneumothorax. C. Congenital hypothyroidism and sepsis only. D. Hyperbilirubinemia and hypoglycemia only. Correct answer is B. Hypovolemia and pneumothorax. Now let's see its explanation. The 2025 neonatal algorithm specifically notes that if the HR remains less than 60 per minute, the team should consider hypovolemia and pneumothorax. This becomes especially important in NICU trap scenarios after intubation, PPV, or compressions. Question number 31. A 40-week newborn is brought to the warmer. After warming, positioning, drying, and stimulation, the infant is apneic with a heart rate of 90 per minute. A team member says, the heart rate is not below 60, so let's just watch for another minute. What is the best next step? A. Observe for another minute. B. Start PPV immediately. C. Start chest compressions. D. Give epinephrine. Correct answer, B. Start PPV immediately. So what about its explanation? A neonatal trap is confusing the HR less than 100 per minute threshold for ventilation with the HR less than 60 per minute threshold for compressions. If the newborn is apneic or gasping, or HR is less than 100 per minute after initial steps, the next action is positive pressure ventilation. Question number 32. A newborn is receiving mask PPV during transport from the delivery room to the NICU. The heart rate is 58 per minute, but chest rise is poor. Which action is best? A. Begin compressions immediately because HR is below 60 per minute. B. Optimize ventilation first and ensure effective chest movement. C. Give epinephrine through the ET tube now. D. Stop PPV and reassess in 30 seconds. Correct answer, B. Optimize ventilation first and ensure effective chest movement. Let's see its explanation. Before compressions, neonatal resuscitation requires effective ventilation that inflates the lungs. If chest movement is poor, the correct move is to correct ventilation, not jump straight to compressions or medication. Question number 33. After ventilation is corrected and chest movement is visible, the newborn's heart rate remains 52 per minute. What is the best next step? A. Continue PPV alone because the lungs are now inflating. B. Start coordinated chest compressions at 3:1 with ventilation. C. Give sodium bicarbonate. D. Switch to blow-by oxygen. Correct answer, B. Start coordinated chest compressions at 3:1 with ventilation. Now let's see its explanation. If the heart rate remains less than 60 per minute after effective ventilation, chest compressions should begin. The neonatal ratio is 3:1, reflecting the primary importance of ventilation in newborn arrest. Question number 34. During compressions, the infant is intubated but still on 30% oxygen from earlier stabilization. What is the best oxygen action now? A. Continue 30% oxygen to reduce oxidative injury. B. Increase to 60% oxygen only if cyanosis persists. C. Use 100% oxygen during compressions. D. Discontinue oxygen temporarily. Correct answer, C. Use 100% oxygen during compressions. Let's see its explanation. The 2025 neonatal algorithm specifies 100% oxygen during chest compressions. Once compressions are no longer needed, oxygen should then be titrated back to target saturation ranges. Question number 35. A newborn remains bradycardic after effective ventilation and 60 seconds of coordinated compressions. UVC placement is not immediately successful during NICU handoff. What is the best next access plan? A. Keep trying UVC only. No other access is acceptable. B. Use IO access if IV/UVC is not feasible. C. Stop compressions while waiting for line placement. D. Avoid vascular access and use only repeated ET doses. Correct answer: B. Use IO access if IV/UVC is not feasible. Now let's see its explanation. The 2025 neonatal algorithm allows UVC or IO access. UVC is standard, but IO is acceptable if IV access is not feasible, especially in a deteriorating infant. Question number 36. The infant receives intravascular epinephrine, but the heart rate remains 45 per minute. When should the next epinephrine dose be considered if the infant still meets criteria? A. Every 30 seconds. B. Every 1 minute. C. Every 3 to 5 minutes. D. No further doses should be given. Correct answer: C. Every 3 to 5 minutes. So what about its explanation? The algorithm specifies UVC or IO epinephrine every 3 to 5 minutes if the heart rate remains below 60 per minute despite appropriate ventilation and compressions. Question number 37. A 33-week infant on CPAP is being transported from the delivery room to the NICU. At 5 minutes of life, pre-ductal saturation is 83%. One provider wants to rapidly increase oxygen because the baby is still too low. What is the best interpretation? A. The saturation is below expected and mandates 100% oxygen. B. The saturation is within the target range for 5 minutes of life. C. The value proves severe hypoxemia requiring intubation. D. Pre-ductal saturation targets are not useful in transport. Correct answer: B. The saturation is within the target range for 5 minutes of life. Now let's see its explanation. The accessible 2025 algorithm gives rising pre-ductal targets including 80 to 85% at 5 minutes and 85 to 95% at 10 minutes. A saturation of 83% at 5 minutes fits the expected range. Question number 38. A 35-week infant continues to need effective ventilation during handoff to NICU. Mask ventilation is ineffective, and intubation attempts have failed. What is the best next airway option? A. Keep using ineffective mask ventilation. B. Start chest compressions first. C. Use a laryngeal mask as an alternative airway. D. Delay intervention and observe. Correct answer: C. Use a laryngeal mask as an alternative airway. Let's see its explanation. For infants 34 weeks or more, a laryngeal mask is a reasonable alternative when face mask ventilation is unsuccessful or endotracheal intubation is not possible or unsuccessful. Question number 39. After initial improvement in the NICU, a recently resuscitated infant suddenly becomes more bradycardic, oxygen need rises, and chest movement worsens after PPV and airway placement. Which reversible cause should be strongly suspected? A. Hyperbilirubinemia. B. Pneumothorax. C. Necrotizing enterocolitis. D. Seizure alone. Correct answer: B. Pneumothorax. What about its explanation? If heart rate remains low or the infant deteriorates despite appropriate resuscitation, the algorithm specifically tells teams to consider pneumothorax as a reversible cause. In the setting of appropriate resuscitation and pallor, this trap is especially important. Question number 40. A pale infant with placental abruption required extensive resuscitation and remained severely bradycardic despite ventilation, compressions, oxygen, and epinephrine. During NICU handoff, which additional cause should the team prioritize? A. Hypovolemia. B. SVT, C. Metabolic syndrome, D. Hyperbilirubinemia. Correct answer, A. Hypovolemia. Now let's see its explanation. The neonatal algorithm specifically highlights hypovolemia as a cause to consider when the infant remains profoundly compromised despite standard resuscitation steps. In the setting of appropriate and pallor, this trap is especially important. Question number 41. A vigorous term newborn is crying with good tone immediately after birth. Which action is most appropriate regarding cord management? A. Clamp cord immediately in all infants. B. Delay cord clamping for at least 30 to 60 seconds if no resuscitation needed. C. Milk the cord routinely in all term infants. D. Begin PPV before drying the infant. Answer: B. Delay cord clamping for at least 30 to 60 seconds if no resuscitation needed. Let's see its explanation. For vigorous newborns not needing resuscitation, delayed cord clamping for about 30 to 60 seconds is commonly recommended. Question number 42. A newborn receiving PPV has no chest movement after mask repositioning and airway repositioning. What is the next best step? A. Start chest compressions. B. Increase pressure gradually while observing chest rise. C. Administer epinephrine. D. Stop PPV and reassess in 5 minutes. Answer: B. Increase pressure gradually while observing chest rise. So what about its explanation? For early corrective steps failed, increase inflation pressure as part of MRSOPA to achieve visible chest movement. Question number 43. Which monitoring method gives the fastest reliable heart rate during active neonatal resuscitation when available? A. Pulse oximetry alone. B. Umbilical pulse palpation only. C. ECG monitoring. D. Capillary refill. Answer: C. ECG monitoring. Now let's see its explanation. ECG provides rapid and accurate heart rate assessment during resuscitation. Question number 44. A preterm infant is breathing spontaneously but has persistent retractions and low oxygen saturation. Best initial support. A. CPAP with blended oxygen titrated to targets. B. Immediate chest compressions. C. Routine intubation for all preterms. D. 100% oxygen by face mask only. Answer: A. CPAP with blended oxygen titrated to targets. Let's see its explanation. CPAP supports spontaneous breathing and blended oxygen can be titrated to target saturations. Question number 45. During coordinated neonatal CPR, what finding best suggests compressions can be stopped? A. SpO2 reaches 100%. B. Heart rate rises to 65 per minute. C. Heart rate rises to greater than equal to 60 per minute. D. The infant opens eyes. Answer: C. Heart rate rises to 60 per minute. So what about its explanation? Chest compressions are stopped once HR is 60 per minute or greater. Continue ventilation until HR and breathing improve further. Question number 46. A newborn remains bradycardic despite effective PPV and compressions. What route is preferred for epinephrine? A. Intramuscular. B. Umbilical venous route. C. Oral. D. Subcutaneous. Answer: B. Umbilical venous route. Now let's see its explanation. Umbilical venous access is the preferred route for epinephrine during neonatal resuscitation. Question number 47. Why is effective ventilation emphasized more than compressions in most neonatal arrests? A. Most arrests are caused by dehydration. B. Most arrests are primarily cardiac in origin. C. Compression injuries are common. D. Most arrests are primarily respiratory in origin. Answer: D. Most arrests are primarily respiratory in origin. So what about its explanation? Neonatal bradycardia or arrest is usually caused by hypoxia and inadequate ventilation. Question number 48. A newborn on PPV suddenly develops asymmetric chest rise and worsening saturation. Priority concern: A. Hypoglycemia, B. Hyperthermia, C. Pneumothorax, D. Sepsis. Answer: C. Pneumothorax. Now let's see its explanation. Sudden deterioration with asymmetry during PPV raises concern for air leak or pneumothorax. Question number 49. Which temperature strategy is best immediately after birth for a very preterm infant? A. Leave uncovered to avoid overheating. B. Use warmer plus plastic wrap or bag and hat. C. Bathe infant quickly. D. Delay temperature control until NICU. Answer: B. Use warmer plus plastic wrap or bag and hat. Now let's see its explanation. Very preterm infants are at high risk for hypothermia. Thermal protection should begin immediately. Question number 50. After a successful resuscitation, which post-event action reflects 2025 update? A. End monitoring once crying. B. Post-resuscitation care, family communication, and team debriefing. C. Immediate discharge to mother only. D. Avoid documentation until later. Answer: B. Post-resuscitation stabilization, communication with family, and team debriefing. So the explanation is: post-resuscitation stabilization, communication with family, and team debriefing are emphasized. You've just completed the AHA AAP NRP 2025 updated exam preparation session. If you found this session helpful, continue exploring more AHA updated contents, practice more scenario-based questions, and stay committed to delivering the highest standard of care for every newborn. Thank you for learning with us, and see you in the next session. Like, share, and comment to support better newborn care, and subscribe for more AHA updated videos.